Okay, here we are on Chapter 18, Drugs, our final chapter on pharmaceutical drugs, over-the-counter and prescription drugs, that is. And this will provide an excellent opportunity for us to take a look at all of the general organic and biochemical knowledge we've acquired during our time together. Alright, our learning outcomes for this chapter include being able to identify common drugs such as natural, semi-synthetic, or synthetics, define the term chemotherapy and explain its origin. We'll be able to list some common over-the-counter analgesics, antipyretics, and anti-inflammatory drugs and describe how each type works. And we'll be able to name several common narcotics, describe how each functions, and state its potential for addiction. In addition to those learning objectives, we'll be able to list the common antibacterial drugs and describe the action of each. We'll name the common categories of antiviral drugs and describe the action of each of those as well. We'll describe the action of the common types of anti-cancer drugs, and we'll define the terms hormone, prostaglandin, and steroid, and explain the function of each of those as well. Okay, continuing with the many learning objectives we have for this chapter, we'll list the 3 types of sex hormones and explain how each acts and how birth control drugs work. We'll describe the action of 4 types of drugs used to treat heart disease, one of the most common disorders in the United States. And we'll explain how the brain amines norepinephrine and serotonin affect the mind and how various drugs change the action of these substances. Continuing with our many things to do this chapter, we'll be able to identify some stimulant drugs, depressant drugs, and psychotropic drugs and describe how they affect the mind. We'll differentiate between drug abuse and drug misuse, so the little subtlety there, and we'll describe how a new drug is developed and brought to market. Okay, and finally, like we usually do, we'll end with some green chemistry. We'll identify green chemistry principles that can improve the E factor of chemical syntheses for pharmaceuticals, and we'll explain how prodrugs can be important for drug delivery and for green chemistry. So lots of things to accomplish and lots that you should know and be able to do after this chapter, so let's get right to work. Okay, so before we start, it's probably important that we define the term drug. It actually comes from the German word Trug, which means to dry, and this goes with the Western European tradition of drying herbs as pharmaceuticals, as medicines, back before we had anything else at our disposal. Of course, other cultures had been using similar approaches, but in the Western world, and the German term in particular, Drug, is what gives rise to our English word drug. And the definition of a drug is any chemical substance that affects the function of living things and is not necessary for that living thing. We have lots and lots of substances in our body that we make that are necessary for life. Drugs are something from outside that's not necessary, but that has a physiological effect. So we use drugs for a number of reasons. They can be used to relieve pain, treat illness, or improve health and well-being, as you see here on the slide. And we get them from many different sources. We can obtain these drugs from plant sources, microorganisms, marine organisms, and being brilliant chemists, we can make our own drugs as well. So we have fully synthetic drugs at our disposal nowadays. So taking a look at a couple of these sources, we see a plant source there on the left, and then a marine organism source on the right. So as we've already mentioned, these drugs can come from lots of different sources, and ultimately the natural sources, things like Taxol, which comes naturally from a plant source in the rainforest, can then be either made synthetically or modified as a synthetic drug. Okay, so we've known for quite some time now that certain drugs can be useful because they have differential toxicity, and if we look at the slide, Paul Ehrlich determined that idea back in the late 1800s, early 1900s, and He's the first person to coin the term chemotherapy when he's referring to using chemicals to treat disease states, and he was awarded the Nobel Prize in Physiology or Medicine in 1908, just several years after the prizes started. So again, the dose makes the poison, so to speak, to quote Paracelsus. And in this case, it's better to take something that has some toxicity for you and your cells if it's more toxic to the disease that's causing trouble for you. And as I said, we've known that for well over 100 years. Okay, one of the most common reasons to take a drug would be for pain relief, and one of the major classes of pain relievers would be the non-steroidal anti-inflammatory drugs, or the NSAIDs, and they work by relieving pain and reducing inflammation by blocking the production of prostaglandins, these substances that our body makes naturally that are associated with inflammation. And the NSAIDs include a number of substances, aspirin, which ultimately derives from white willow bark and has been used for thousands of years as a pain reliever in that form, but over-the-counter aspirin, ibuprofen, and acetaminophen would all fall into the class of NSAIDs, so among the most commonly taken and among the longest known groups of pain reliever drugs. So in addition to its notable activities as a pain reliever, aspirin has been used for the last several decades in order to prevent stroke and damage due to heart attack. So this tends to be a very low dose, sometimes called baby aspirin, and this low dose, the 81 milligram dose, seems to have a lot of protective effect. And it can be buffered, which means, of course, because the aspirin itself is an acid, acetyl salicylic acid to be specific, which is converted by the body into salicylic acid. It can be buffered if it's causing trouble for the stomach. Aspirin itself will cause some stomach bleeding, so if you buffer it first, that tends to help patients have a better tolerance for it, especially if they're going to be taking that dose of 81 milligrams every day for the rest of their life. And again, the major source of the anticoagulant properties seem to be the protective therapeutic value here that allows for this heart attack and stroke prevention by thinning the blood, by getting rid of these prostaglandins, which can help cause the blood to clot. Another noteworthy impact that these NSAIDs have is to be fever reducers. So in addition to being pain relievers and stroke and heart attack preventers, they have this ability to lower fever. Fevers, of course, are caused by things like the pyrogens that get released by leukocytes and other circulatory cells. So it's our body that's doing this. We're trying to raise the temperature in order to cause the invaders to lose traction here. And of course, that's very undesirable for anyone who's had a fever, and it's particularly dangerous for young children and the elderly. So these NSAIDs, which, as we've already said, work on the prostaglandins, and the pyrogens also use the prostaglandins as secondary messengers. The NSAIDs will block that production and therefore help to reduce fever. So they can be pretty effective individually or combined. If you do things like acetaminophen and ibuprofen combined, they can bring down a fever very quickly, which is helpful for young children and the elderly, as I mentioned already. Okay, so a little more about how those NSAIDs work. They help to block the production of cyclooxygenase, or COX enzymes. You may have heard a lot of the advertisements, which strangely are drug companies advertising directly to the consumer to talk to your doctor about these different things. They'll often say that the drug is believed to act by blocking the COX-2 enzyme, for instance, for some of these things like Celebrex, which was on the market, then off the market, now on the market again. And those COX enzymes work on the production of prostaglandins from arachidonic acid, and the best known ones, the COX-1, which is found in the stomach and kidney tissues, and then that COX-2, which is the more common target because it's found in tissues where inflammation occurs. That's how those NSAIDs work, by blocking that particular general COX-2 enzyme. And as you see, aspirin, ibuprofen, and naproxen, which is under the trade names. Well, aspirin doesn't really have a trade name since it's been known for some time. Bayer was the first mass producer of it. Ibuprofen is commonly known as the trade name Advil, and then naproxen by the trade name Aleve. All these block both of those COX enzymes, COX-1 and COX-2. Of course, blocking that COX-1 can lead to the side effects of excessive bleeding and stomach pain, so a number of people who may have stomach problems won't use those three, but would rather go for something like acetaminophen that blocks COX-2 and doesn't have the excessive bleeding and stomach pain side effect. Alright, so as I said, some of these newer ones in particular block only that COX-2 enzyme, so they don't have those stomach pain and bleeding side effects that the older NSAIDs do. However, they have their own host of side effects. Some of them can cause increased risks of heart attack and stroke, as well as allergic reactions or internal bleeding. And we see here Celebrex, that particular substance that I mentioned for having that commercial where they talk specifically about the COX-2 enzyme. So as you see, aspirin is the one that we tend to use to prevent a heart attack and stroke, and some of these newer ones actually increase the risk of heart attack and stroke. Okay, so acetaminophen. Again, acetaminophen helps to reduce pain and lower fever, and it's not anti-inflammatory, and it's not an anticoagulant, so it's not useful for those things. It acts by blocking COX-3, and I think I may have misspoken and said COX-2 earlier, but COX-3 enzyme specifically for acetaminophen, and this allows for, again, not those undesirable effects of blocking COX-1 in particular, so you don't have the bleeding and stomach pain, and therefore this acetaminophen can be taken by children, by those who are affected by the side effects of aspirin, in particular the stomach issues with that aspirin acid. It doesn't mean it's entirely safe, and it can cause liver and kidney damage in large doses, overdoses, or daily abuse. But you also need to avoid alcohol when taking acetaminophen. But again, it tends to be the first of these NSAIDs that are used for young children because of its relatively mild side effects and its good effects on pain and fever. We also tend to see combination pain relievers, which might have a combination of 2 or more NSAIDs, as well as some other substances. Caffeine, for instance, can increase the effects of the NSAID pain relievers. So it's called a synergistic effect. Caffeine, along with acetaminophen, for instance, works better than just the acetaminophen itself. Even though the caffeine is not affecting those enzymes, its presence, and likewise antihistamines or other drugs, just the presence of those other substances increase the effect of the therapeutic substance. Excedrin and Anacin are familiar brands that tend to have caffeine, as well as either aspirin or acetaminophen, or both aspirin and acetaminophen along with the caffeine in there. So if you've ever taken those substances and found them to be more effective than just Tylenol or ibuprofen, then that's why. Many of us are affected by the common cold, and there's so many variants of the common cold that we tend to be affected at least once a year, if not more than once a year. And there's a lot of things that they sell over the counter that are supposed to help, and again, because of the common cold family of more than 200 viruses, and the fact that it's not able to be cured, most of us have tried pretty well everything. But these things only treat the symptoms. They might reduce the fever, take care of some of the pain. Oftentimes, if you go to a walk-in or see your physician. You'll also end up with an antibiotic that does absolutely nothing but make you feel like you got something, you got a prescription, and therefore it's going to help. Really, the only thing to do is wait it out, and if the symptoms are causing you discomfort, then go for these medications that treat the symptoms, but really they don't attack the root cause of the cold. They don't shorten the length of the cold. They just help you to manage those symptoms. And the periodic FDA reviews do help to make sure that the medications are safe and effective, but again, they're not cures by any stretch. Okay, another large class of drugs are the antihistamines, which relieve the symptoms of allergies caused by the actions of histamine. Histamines are released by certain cells when an allergen binds to their surface, and histamines cause the redness, swelling, and itching that we associate with the allergic reaction. So a number of these antihistamines are important for people who have severe allergies. They can take these things like EpiPens to help cause immediate decrease in swelling, where the swelling could be even life-threatening. If people, the throat swells up, that affects the breathing airway passage, and that's important to be able to act quickly. So here we see a few of the common ones. In the middle there, B. So histamine is A, the problem compound, so to speak. And then B, diphenhydramine, that's your typical Benadryl, as it's known by its trade name, but certainly been around quite a while and quite inexpensive as a generic. And then cetirizine there is also one of these newer antihistamine type drugs that you can get either over the counter or by prescription. And thinking of the common cold, cough suppressants, antitussives to be particular, include two narcotics, codeine and dextromethorphan. And the codeine is the pain reliever, the more effective pain reliever, so that's by prescription only, but dextromethorphan you can get over the counter. And in addition, the antihistamine diphenhydramine, there, the Benadryl that we saw on the previous slide, has been found effective by the FDA. Of course, it does still cause that drowsiness that anyone who's taken it for any of its reasons has already found, so that's a good nighttime cough suppressant. And you certainly wouldn't want to operate heavy machinery or do any of that label advice, go off label by doing any of those activities until you know how that antihistamine affects you. So if you have a severe cold, stopping the cough, as we talked about in the previous slide, is one goal, but actually clearing up the mucus is what we would hope to do, and that's the purpose of expectorants, to clear those bronchial passages. However, there's only really one expectorant, glyceryl guaiacylate, or guaifenesin, as it's commonly known, is the only one that's been found effective, and even that one is only marginally effective, and it's fairly expensive, as it's the only one out there. So try it if it works for you, great. If not, don't be surprised, because it really doesn't have great activity. You can certainly try some decongestants, and they're inhaled through the nasal passage, and they seem to be safe and effective for the occasional use if you have a cold. And there's a number here that we list, but that last one, phenylephrine, if you think about Sudafed or pseudoephedrine rather, for the trade name Sudafed, that one has been used the longest probably, and it continues to be effective, although it's associated with the production of methamphetamine. So you have to go and get your license out and keep track of how much is being purchased at the pharmacy, because they want to make sure that you're using it for its intended purpose. Phenylephrine, not quite so easy to convert to make methamphetamine, and so that one you can buy over the counter without having to give away your license and address and all the other information. Okay, narcotics. Narcotics specifically are drugs that produce narcosis, stupor, or general anesthesia. and are analgesics as well. They also kill pain, like the NSAIDs we already talked about. Narcotics that are addictive are regulated by law in the United States, and oftentimes the term narcotics, or to call someone a narc, for instance, has the connotation that it's any illegal drug, any drug that's abused commonly. And of course that's not true. It's a specific class of drugs, but you'll often see that in forensic settings, that the narc, the sort of anti-drug unit, that they'll often call them narcs, and the idea of narcotics is being used generically to mean any illegal drug. So just be careful. Now you know better, but most of the rest of the people who watch those shows don't know any better. Okay, looking at some very potent narcotics, opium and morphine. Opium is the resinous juice of the unripe seeds of the oriental poppy. And that's a common theme, that idea of the resin having a lot of this active compound. The same sort of thing with marijuana. The resin there of the marijuana leaf, the marijuana plant rather, the resin is the most concentrated source of that active compound. Here we see the same thing with opium. There are more than 20 alkaloids, sugars, resins, and waxes that that plant contains, and opium is a mix of all of these. Morphine's one alkaloid that makes up about 20% of the weight of opium. So opium itself has been used, or rather abused, by humans for quite some time. Morphine, being able to extract morphine in particular from the opium, is a more recent phenomenon. Now that we have the capability of doing that, you see morphine and of some of these other alkaloids being made and abused. They're also useful. Morphine in particular is a useful therapeutic. Because of its addiction, it's usually only used for end-of-life patients, terminal cancer patients, for instance, where you don't have to worry about weaning them off of the drug, because unfortunately their life expectancy is not so long, and there's probably no chance of them having to go back off of morphine. Codeine and heroin, looking at some derivatives there of morphine. Codeine is a derivative of morphine made by replacing that phenolic hydroxyl group with a methoxy group to convert that morphine into codeine, and obviously it makes it much less addictive. Probably most of you in the class have been on a cough suppressant, a cough syrup that contains some codeine at some point in your life. So obviously it's not nearly as addictive if we're going to be adding it to cough syrups with that frequency. Heroin is made by converting both hydroxyl groups of morphine to acetate esters, and this makes heroin less polar than morphine and more soluble in fatty brain tissue. And unfortunately, heroin has become a commonly abused drug in our area nationwide, and it's sort of typically a drug that's used by individuals who've abused prescription drugs, and then they can't get the prescription refilled anymore, or get that prescription drug. So heroin seems like the next drug. It's a drug that seems like medicine, and you don't seem like you're a drug addict in the eyes of most of the heroin abusers, and that's tends to be the population. And it's very unfortunate, but that's what tends to happen in those cases. Looking at the idea of synthetic narcotics, and we've looked at a lot of things. There's active research now on a lot of snake venoms, for instance, as painkillers. But one of the drugs that has been found, a synthetic narcotic, to be as effective, or not quite as, but nearly as effective as morphine, but less addictive, is methadone. And methadone is used to treat heroin addiction. In the 80s and 90s, you used to have methadone clinics to treat addicts. Nowadays, unfortunately, with the heroin epidemic growing again, you're seeing methadone being used again, although it's not commonly done in these methadone clinic type settings like it used to, but it is being used again to try to combat that heroin addiction that is plaguing, as I said, our region and the nation. Okay, we see here table 18.1 from the text with some synthetic narcotics. We see not only the substance, but also the duration of action in hours, and the approximate oral dose equivalent to 30 milligrams of morphine. And we have some other options out there. Fentanyl you may have received if you've ever been in pretty severe pain in a hospital setting. And here it doesn't last as long as morphine, but it does have a pretty small dose, less than a milligram, to have the equivalent pain-killing abilities of 30 milligrams of morphine just for that 1 to 2 hours. So it's commonly given intravenously in the hospital setting, or it can be used in transdermal patches for chronic pain. Some other Demerol there, for instance, we see in a couple different forms there, and depending on the form and the hours of action, you may have equivalent dosage that 300 milligrams to get to 30 milligrams of effective morphine amounts, or just 7.5 for the hydromorphone variety. And then methadone, as we said, is typically used for heroin addiction, not for pain relief, so we don't bother to calculate that approximate oral dose. And here we see the chemical structures for some of those synthetic narcotics. So you see they tend to have at least one benzene type ring, and then depending on the specific, you see some other activity there. In the case of the Demerol there, you see the nitrogen as part of that heterocyclic ring, and then we have some nitrogens in various areas of the other substances. Okay, we have some morphine agonists and antagonists here. Morphine agonist would exhibit morphine-like activity by binding to those same receptors in the brain. And a morphine antagonist would inhibit the action of morphine by blocking those receptors and therefore not allowing the morphine to bind. So pentazocine acts as both. It's an agonist and an antagonist. It's less effective than morphine, but it is effective. I'm sorry, less addictive than morphine, but it's still effective at relieving pain. And naloxone is a pure antagonist. It can be used to treat opium addicts, so that the feel-good binding sites of morphine are no longer available, and they don't get that same high that they would if they weren't on the naloxone. Okay, so natural opiates, if we look at endorphins, these are morphine-like peptide chains that are produced in response to pain. Morphine and endorphins bind to the same receptors, and therefore the endorphins give this pain relief and cause what's known as the runner's high. So if we have any runners out there, you already have experienced that. There's also some research that suggests learning gives rise to endorphins and gives the brain a natural high. So just listening to the lectures and reading the text and doing all your work in the course, you should be producing some endorphins and having your brain reward itself for all that hard work. Okay, on to another huge class of drugs, antibacterial drugs. If we look at these values here to the right, the top value is from 1900, and it shows infectious disease being the major causes of death back in 1900. Now if we look, I think it's 2011, we have heart disease and cancer as the major diseases. And again, those tend to be old age diseases. At least heart disease tends to affect those of us in our later years, and cancers can strike at any age, but we tend to associate them more with people who are more advanced in years. So that's a very good sign that our diseases that tend to lead to death are associated with older age diseases rather than infectious diseases that could strike anyone at any time. Alright, so the way that we were able to decrease the devastation of those infectious diseases was through antibacterial drugs like the sulfa drugs. The sulfa drugs were the first antibacterial drugs. Sulfanilamide acts by replacing para-aminobenzoic acid, which the bacteria need to manufacture folic acid. So they're not able to live and thrive without it, and the sulfa drugs were able to kill a number of bacterial disorders that were causing, as you saw in the previous slide, a lot of infectious diseases and deaths. Okay, looking at penicillins, these are antibiotic substances, antibacterial drugs that are derived from molds or bacteria, and they're soluble substances that interfere with the growth of other microorganisms. Penicillins work by inhibiting enzymes that bacteria use to make their cell walls. Of course, humans, animal cells have no cell walls, so that doesn't affect us, but just as you saw in the previous slide with the sulfanilamide and the paraminobenzoic acid, differing mainly in that sulfur where you would see a carbon with the paraminobenzoic acid, we see general formulas here that have modifications, and they bind to these enzymes that the bacteria use because they fit the enzyme active site, but they don't release. So they are similar to some substrates, but they stay in there instead, and we see general formula there for the penicillins, and you have in the middle penicillin G, and then finally amoxicillin at the far right is letter C there on the slide. So similar chemical structures and just different activities, different tolerances. Unfortunately, people can be allergic to these penicillins, and so therefore obviously you wouldn't use those particular drugs, especially if penicillin G, if there's an allergy, you might try amoxicillin or vice versa, but you may need to go out of the penicillins altogether if they're not tolerated by a particular patient. Okay, so with the advent of the antibacterial drugs and the ability to therefore stop a number of infectious diseases from taking countless lives each year, things seemed great, and it seemed like we should just keep going. And why stop a good thing? Why not just put antibacterial agents into soaps and lotions and just all over the place? Well, unfortunately, bacteria have developed resistances to certain antibiotics, and that's a problem because now these drugs are no longer effective against those bacteria that are resistant. So we have to stay ahead of the game here, and we're always trying to devise new and more potent antibiotics to kill those resistant strains of bacteria. The penicillins, because they're an older class of antibiotics, have a number of disease-resistant, penicillin-resistant bacteria, so they've been partially replaced by cephalosporins such as cephalexin, known in the trade name Keflex. So we see here the structure of cephalexin, and that, again, tends to be pretty useful because there aren't many bacterial strains that have developed resistance, but the more that cephalexin gets used, the more likely we're going to have resistant strains of bacteria, and we'll need to find another antibacterial drug that's effective against those cephalexin-resistant bacteria that we'll undoubtedly find because of our overuse of now this replacement drug. Looking at some other options, we have the tetracyclines, and they're broad-spectrum antibiotics that act by binding to bacterial ribosomes, and this inhibits protein synthesis and therefore kills the bacteria. And we see a number of options here: tetracycline itself, and then chlortetracycline in the middle there, and oxytetracycline there at the end. And very similar chemical structures, just slight changes where you see those green, either the chloro group there in the chlortetracycline or the hydroxy group there in the oxytetracycline. Okay, in concluding our discussion of the antibacterial drugs, we have the fluoroquinolones, which are broad-spectrum antibiotics first introduced in 1986, so just over 30 years now of use. They act by inhibiting DNA replication through the interference with the enzyme DNA gyrase. Ciprofloxacin, or Cipro, you see the trouble I had, that's why it's ordinarily just called Cipro by trade name, is the leading fluoroquinolone, and again, because these are newer additions to the arsenal, they tend not to have the widespread issues of bacterial resistance, but as we've seen in the past, the more we use something, the more likely we are to find those resistant bacteria. So for now it seems to work well, but needs something new before too long after this gets overused. Alright, so on to the viruses and the antiviral drugs. Viruses themselves are composed of nucleic acids and proteins. Viral diseases cannot be cured by antibiotics, despite the fact that oftentimes you'll go to a physician or other healthcare provider and be seen for something that's most likely the common cold or some other viral infection and be given an antibiotic, and that goes right back to what we were just saying, where the overuse of antibiotics gives rise to the disease-resistant bacterial strains. So that's the exact problem we're trying to combat. So we do have a few things in our arsenal for antiviral drugs, but as you'll see, nothing that would be wise to give someone who's just experiencing something mild like the common cold. Okay, so looking at viruses, which are really neat, and we'll talk about in a little more detail shortly, but the genetic material for a virus is either DNA or RNA. So DNA viruses enter the host cell where the DNA is replicated and directs the production of viral proteins for new viruses that invade other host cells and continue the process. So the virus has taken our cellular machinery and hijacked it to reproduce its own DNA. For an RNA virus, they enter the host cell and induce the synthesis of new proteins. And some of these RNA viruses are what are known as retroviruses, which synthesize new DNA in the host cell. And probably the most famous of these retroviruses is HIV, the human immunodeficiency virus. And it's one of the classic examples of a retrovirus, and it's the virus responsible for ultimately causing AIDS, acquired immunodeficiency syndrome. And so there are some antiviral drugs that have been developed, although they are effective against some viruses, but they don't provide cures. They tend to be needed daily for life, and the problem is viruses themselves are tough to define. If you look at the definition of life, viruses don't do a lot of those life functions outside of the body. Inside a host cell, they can accomplish those sorts of synthesis and nutrition and other sorts of core life processes, but on their own, they don't do a lot of that, and some viruses can be dormant for quite a while and then take over the cell machinery again later on. So these antiviral drugs, we have a few now, but again, there's certainly no cures for most of these conditions. Okay, so a few of these antiviral drugs. We have nucleoside analogs, which substitute an analog for the nucleoside in the viral DNA, effectively crippling it. So you don't get the right, for instance, adenine, thymine, cytosine, guanine that we talked about when we talked about human DNA. We're taking a nucleoside like that the viral DNA needs and replacing it with something else that doesn't allow the DNA to replicate correctly. There's also non-nucleoside reverse transcriptase inhibitors, which stop the reverse transcriptase enzyme from making more copies of the virus. And there's protease inhibitors, which block the enzyme protease so that new copies of the virus can't get out to infect new cells. Okay, so leaving the antivirals and now moving into the chemotherapeutic agents. Cancer is a much dreaded disease. Approximately 1.3 million new cases are diagnosed in the U.S. each year, and certainly some types of cancers have high cure rates, and that's great news. Unfortunately, other types still have very low survival rates. We have had a number of anti-cancer drugs, dozens of them, in fact, and different anti-cancer drugs are commonly used for different types of cancers. However, with any of them, the drugs that kill the cancer cells also damage normal cells. One of the reasons that cancer is such a dreaded disease is that it's our own cells that have sort of gone haywire. They are our cells, but they aren't behaving themselves. They're going and dividing at an uncontrolled rate, and they're not forming the certain types of tissue or cell types that they were supposed to be, and that's what makes it so tough, is they are our cells, and our immune system doesn't go after them for that reason usually, but we need to kill them, but we don't want to damage the normal cells. One major group of chemotherapeutic agents is the antimetabolites, which closely resemble a substance used in normal metabolism and interfere with the physiological reactions of the cancer cell. Again, I mentioned previously that cancer cells are dividing rapidly, which is a problem for us because then they form these tumor masses. But by taking the antimetabolites, even though they affect both healthy and cancer cells, since the cancer cells are dividing at the faster rate, they're more likely to be negatively impacted. So we have 6-mercaptopurine, 6-MP as it's known, 5-fluorouracil, and 5-fluorodeoxyuridine are some examples of things that get incorporated into the nucleotides, but they don't work well. They inhibit the formation of thymine-containing nucleotides during DNA synthesis, and that'll slow the division and growth of the cancer cells. It will affect normal cells as well, but as we said, the cancer cells are the ones more rapidly dividing, and therefore more likely targeted. However, epithelial cells, like the cells that line the digestive system, skin cells, hair cells, these tend to also be affected. And that's why you tend to get nausea and hair loss and other skin conditions as a result of taking some of these antimetabolite drugs. Here we see an image that shows the chemical structure of 6-mercaptopurine and then adenine, which we know is one of the core nucleotides, and they're very similar in structure, a thiol instead of an amine there in the position that we see up top. Because they resemble these things that are needed, but they don't behave like the needed substances, that's what causes the cell death in the cancer cells and unfortunately in healthy cells that are affected. Another group of anti-cancer drugs are the nitrogen alkylating agents, which are relatives of the old mustard gases used during World War I, and they act by cross-linking DNA strands and hindering replication. Cyclophosphamide, which is known by the trade name Cytoxan, is used to treat Hodgkin's disease, lymphomas, leukemias, and other cancers. And again, it does so by cross-linking those DNA strands and not allowing for DNA replication. Alright, and there's lots of other things which are known simply as miscellaneous anti-cancer reagents, and these other anti-cancer agents can be from plant sources like Taxol, which is used in breast cancer patients, and certain antibiotics even like actinomycin. In addition to these chemotherapy agents, surgery, radiation therapy tend to be used depending on the stage of the cancer, depending on the location of the cancer. Chemotherapy tends to be the broadest and sometimes the first resort, sometimes the last resort, depending on the type of cancer. But again, cancer is a very scary disorder, whether it's a variety that happens to have a high cure rate or a low success rate. Just having the diagnosis of cancer is a scary thing, and hopefully with the chemotherapy, surgical, and radiation therapy options, if you're ever caught with that diagnosis, you'll be able to have a very successful outcome and not have long-term effects from that diagnosis. The key, of course, is early diagnosis. Okay, so looking at hormones. Hormones are the regulators in our body, and they're chemical messengers produced in the endocrine glands, and they have far-reaching impacts on other regions of the body, depending on the particular chemical message they send. Okay, so we see table 18.2 here, some various hormones, and then where they originate, like pituitary hormones from the pituitary gland, or thyroid hormone from the thyroid gland, for instance, and then the chemical nature and the functions of those. So we won't go by them one by one, but certainly check that out on your own in the text. Okay, those prostaglandins we talked about way back when we talked about the NSAIDs. Prostaglandins aren't hormones. They're hormone-like lipids derived from a fatty acid. Similar because they do react with target cells. Different because they tend to act very near where they're produced, whereas hormones themselves tend to be long-range, acting far from where they're produced. The prostaglandins can produce different effects in different tissues and are rapidly metabolized. And they tend to be mediators of hormone action. And then you see there below in A, arachidonic acid itself, and then the derivatives, a couple prostaglandin examples. Looking at another group of hormones, we have the steroid-based hormones. Steroids themselves are lipids with a definite four-ring skeletal structure, and many drugs are based on steroids. Some are the illegal drugs, the anabolic steroids used to enhance athletic performance, and they've affected pretty well any athletic pursuit. Baseball's been in the news a lot, golf even for steroid abuse. Others are used to treat arthritis, asthma, dermatitis, eye infections. So, legally prescribed steroid hormones, steroid drugs to treat those. And you see those four options that we have, they all have that characteristic four-ring structure based on cholesterol. The sex hormones are steroid-type hormones, and we have the androgens that stimulate or control the development of masculine characteristics, and we have the estrogens that are compounds that control female sexual functions. And so we see here testosterone, a very common androgen, an important androgen that has, again, both male and females produce it, and it has certain effects in both genders. Then we have the estrogens, estrone, estradiol, and then progesterone. So on the previous slide we had progesterone. We have also progestin, which is any steroid hormone that has the effect of progesterone. So progestins are effective for female birth control because they fool the body into acting as if it were already pregnant, and therefore blocking ovulation. One of the key features of pregnancy is the failure of the female to ovulate on that monthly cycle because the body already has the fetus, embryo or fetus, I guess, depending on how far along you are, to take care of. So by using these progestins and tricking the body into thinking there's already a fertilized egg that's become either an embryo or a fetus, depending on gestational age, there are no more ovulation releases of eggs, and therefore no chance of becoming pregnant. So now sometimes the progestins do fail, and there is still pregnancy that occurs, but that's rare. The progestins rely on tricking the body into thinking it's pregnant. Emergency contraceptives, on the other hand, are used to prevent pregnancy after unprotected intercourse. So these ECPs, emergency contraceptive pills, can contain both estrogen and a progestin, or just a progestin, and they disrupt the hormone patterns needed for pregnancy. So if the egg was fertilized by that unprotected intercourse, that fertilized egg won't be able to implant. So it is a different target, and you don't tend to have the emergency contraceptive fail, although sometimes those progestin-based contraceptives can fail and pregnancy can resolve. As we just mentioned, those emergency contraceptives can prevent pregnancy after unprotected intercourse. Intrauterine devices, IUDs, are other types of sort of a mechanical device, typically, that interferes with sperm transport and fertilization, or just won't permit that fertilized egg to embed in the uterus. So sometimes it's just a matter of creating a hostile environment there. So depending on the goal, again, all of this will prevent pregnancy, but the progestins will prevent conception, whereas the emergency contraceptives and IUDs will allow conception in cases, but will prevent implantation. So probably the most famous emergency contraceptive, mifepristone, RU486 as it's more commonly called, the so-called morning after pill or medical abortion pill, inhibits progesterone, and this will prevent the body from maintaining pregnancy. Sometimes progesterone itself is given to a woman who wants to maintain a pregnancy that may have indications that it's not doing well, But in this case, by inhibiting progesterone, the body will terminate the pregnancy on its own. And so, certain groups have religious beliefs or ethical issues with this particular substance, whereas others may not. And clearly, if it's prescribed, it's done so legally and done so with the woman's knowledge that this pill is going to prevent the body from maintaining any pregnancy that may have resulted from that unprotected intercourse. Okay, so moving out of pregnancy and talking now about drugs for the heart. The drug treatments for the heart involve increasing blood supply, normalizing heart rhythm, lowering blood pressure, and preventing accumulation of lipid plaque. Pretty well trying to undo all the negative things we in our American lifestyle tend to do to our hearts. Okay, having a normal heart rhythm is obviously an important thing. Arrhythmia would be an abnormal heartbeat, and a number of drugs can treat this through a variety of actions. Fibrillation is a too rapid heartbeat. It's treated with a defibrillator device that are available in many public places, oftentimes in schools and churches and other public places. You'll see a box that holds a defibrillator and hopefully some instructions to let you know how to use it, because it's a very scary thing if it happens, and it can result in death ultimately if a defibrillator device isn't used appropriately in a timely fashion. Treating coronary artery disease tends to be a longer-term process than simply zapping someone with a defibrillator. Arteriosclerosis, for instance, is a blockage of the coronary arteries by lipid-containing plaques. Ultimately, it'll lead to angina pectoris, which is chest pain, and finally heart attack, which obviously can be quite damaging to cardiac tissue and ultimately lead to death if it's not treated promptly. Nitroglycerin, that substance that is indeed a high explosive, right, a secondary explosive. This is a small amount contained in some sort of matrix, so it's not dangerous in that regard. You could drop a case of nitroglycerin pills without having any explosions result. But nitroglycerin and amyl nitrates can be used to treat angina pectoris, and they act by releasing nitric oxide, NO, a very important cell signaler that we didn't actually discover until fairly recently. But by releasing that, we can relax constricted blood vessels. Digitalis can be used to treat heart failure, and digitalis is a mixture of glycosides that release carbohydrates and steroids on hydrolysis, and ultimately was discovered in the foxglove plant. If you remember, we talked about plant sources being important for a lot of therapeutic drugs. Okay, now moving from the heart to the mind, psychotropic drugs affect the human mind and tend to fall into three categories. There's stimulants such as cocaine and amphetamines, which increase alertness, speed up mental processes, and elevate mood. Then you have the depressants such as alcohol and anesthetics, opiates, barbiturates, and tranquilizers, which reduce consciousness and reaction to stimuli, so sort of the opposite of the stimulants. And then finally, you'd have the hallucinogenic drugs, such as lysergic acid diethylamide, LSD as it's known, and marijuana, which alter the way we perceive reality. So if we're going to understand those psychotropic drugs, we have to understand the brain and nervous system. So the human nervous system is made up of about 12 billion neurons. That's a lot of neurons. And the essential parts of the neuron are the cell body, which we see over on the slide, the image rather, to the right, that middle portion there at the top. The axon, which is the long part there in the middle that allows for the image transmit, or the signal transmission finally, and the dendrites, where the dendrites from one cell connect to the dendrites from the neighbor, and that's how these neural networks can rapidly transmit information by electrical impulse. So we see that the messages get transmitted across these fluid-filled gaps, which are known as synapses, by chemicals called neurotransmitters. And these neurotransmitters allow for that electrical signal to be converted into a chemical signal and then passed on to the neighbor for transmission long range across the nervous system. And here we see table 18.3, some inhaled anesthetic agents that are acting as neurotransmitters. Nitrous oxide, we talked about nitric oxide earlier. Nitrous oxide is still currently in use. A lot of the other ones, like diethyl ether and chloroform, that have been known since the mid-1800s, are no longer in use, but nitrous oxide is. It's laughing gas, as it's commonly known, and it's typically used in dentistry. And then you have a few other more recent examples, 1980s and beyond, there at the bottom of the slide. Okay, looking at some brain amines now in depression and mania. Epinephrine is secreted by the adrenal glands, and tiny amounts lead to an increase in blood pressure and cause the fight or flight syndrome, right, where based on evolutionary instincts, we're either going to take on a fight and therefore need that epinephrine, need that increased blood flow and ability to take on that fight, or flight, where we'll need that extra energy to get away from whatever we're confronting. And it's been implicated in some forms of mental illness and just uneasiness, anxiety, where you're sort of always in that fight or flight syndrome is certainly not a good thing. That should be a rare instance where you're up against either that fight or flight response. So speaking of epinephrine, let's talk about norepinephrine, which is a relative of epinephrine and causes feelings of elation and in excessive amounts. That leads to a manic state where everything's great, the person's happy all the time. And deficiency of this mood booster can cause depression. Obviously, if a lot of it causes increased feelings of strong sense of well-being, then a deficiency of it logically causes depression, and that's what we call a biochemical theory of mental illness, where it's based on the presence, excess, or deficiency of particular chemical substances. Looking at another substance that's very important to mood, we have serotonin, which is another brain amine neurotransmitter. It's involved in the regulation of body temperature, sleep cycle, sensory perception, and pleasure sensation. And its metabolite is 5-HIA. And research suggests that reduced flow of serotonin can cause depression. If serotonin's in appropriate amounts gives that idea of sensory perception and pleasure sensation, then reduced amounts can logically lead to depression. And we see tryptophan and 5-HTP as precursors to serotonin, and then, as we mentioned, the 5-HIA as a metabolite. Okay, so a few slides back we talked about epinephrine and then its relative norepinephrine, and we mentioned its importance in normal body and normal brain function. Norepinephrine agonists are stimulants that mimic or enhance the effects of norepinephrine, and they can be used to treat depression, anxiety, obsessive-compulsive disorder, states that are associated with insufficient amounts of norepinephrine. So these norepinephrine agonists increase the effects of norepinephrine and therefore help to treat those states, those disorders. For norepinephrine antagonists, these are drugs that block the effects of norepinephrine, and they can be used to treat hypertension, angina, cardiac arrhythmia, from that sort of manic situation where you've got too much norepinephrine and you're always in that excited state. Okay, moving on to talk about another group of drugs. The anesthetics are substances that cause lack of feeling or awareness. General anesthetics provide unconsciousness and block feelings of pain, so they're useful for things like surgery, where you need the person under general anesthesia so that they don't awaken or feel pain during the procedure. There's also local anesthetics that block feelings of pain in a specific part of the body, and that's desirable for a surgical procedure, for instance, that is localized, and you don't have to worry about the person being awake because you're able to effectively dull the pain in the area of interest, and having the person awake for the procedure isn't going to be a problem. And here we have table 18.4 from the text, which lists a number of commonly used local anesthetics. In particular, lidocaine is commonly used for short procedures or medium procedures, I guess 30 to 60 minutes. Cocaine itself you see down there as medium, although it's fairly rarely used nowadays, and most of the other substances are used in its place. Looking at our modern approach to anesthesia, we've come a long way from chloroform and ether. Modern anesthetics include a variety of drugs such as an orally administered tranquilizer, something given to you by mouth before a procedure, for instance. There's also commonly an IV, such as thiopental, to cause unconsciousness. You could have an injected narcotic painkiller like fentanyl that we talked about earlier in this chapter. There could be an inhalant anesthetic to keep the person unconscious and provide insensitivity to pain. So as long as they're inhaling that, if there's a gas mask and they're breathing that in, then that will keep them out for the length of the procedure. Commonly, there could also be an oral or injected muscle relaxant, such as succinylcholine chloride or another substance like that. So we've got lots of things in our arsenal, and they can be used in combination depending on what the particular situation demands. The local anesthetics tend to be the most popular because they render just a specific part of the body insensitive to pain. They block nerve conduction by reducing the permeability of the nerve cell membrane to sodium ions, and that allows a patient to remain conscious during something like dental work or minor surgery, where you may need the patient awake and aware, but you certainly don't want them to be undergoing the dental work or minor surgery without the aid of the anesthetic, because it would be quite painful otherwise. And so we see here a number of chemical structures of some local anesthetics. They tend to have at least one benzene type ring, and that's a common feature to have that aromatic ring. And you also tend to see an amine group, either an amine right off of the ring, as we see in the 4 to the left, or an amine that's off of the ring and then goes on, a secondary type amine, as we see in lidocaine and mepivacaine, for instance. Barbiturates are a family of related depressant substances. Once used as mild sedatives, they can be used in larger doses to induce sleep, and they're very toxic, and they also tend to have high abuse rates, so they're not used as commonly as they once were. And if you look down at the A, B, and C, we have some barbiturates, some derivatives of barbituric acid, and they differ only slightly from A to B to C, mainly by either the presence of sulfur there in C, where you'd have an oxygen in A and B, for instance. So in particular, you have to be careful about alcohol and barbiturates together. Individually, they're depressants, but when taken together, they have a synergistic effect, sort of like we talked about with caffeine and NSAIDs. A synergistic effect is an effect greater than that of each substance being taken separately. For instance, the depressant effect of barbiturates is enhanced up to 200 times when taken with ethanol, the alcohol that we can legally drink if we're of age in the United States. So that synergistic effect is very dangerous to combine these, and it's just a good idea in general not to take drugs, whether they're prescription drugs or certainly if they're illegal drugs, with alcohol. We also have a large class of drugs known as anti-anxiety drugs, just to deal with the stress of modern life. Right, we have all these stress events, fight or flight type moments that are not what we're evolutionarily coded for, right? We can't really fight or flight a lot of the stresses of modern life. So one class of anti-anxiety agents is the benzodiazepines, and they're thought to act, we don't even know for sure, but it's pretty strong evidence that they act on the GABA receptors, and they are addictive. So diazepam itself we see there, and a couple of derivatives. So just be very careful if you end up having any of these prescribed, because they do have addiction problems. Okay, antipsychotic agents. In 1952, Rauwolfia from the snakeroot plant was used to treat hypertension. That same year, reserpine, again snakeroot, which is where the serpine root comes from, an active alkaloid was isolated from Rauwolfia and found to be an effective sedative as well as an antihypertensive agent. The following year, it replaced electroshock therapy for 90% of psychotic patients. So that's incredible, and unfortunately, that's how we tend to discover a lot of important drug responses, is by accident. This was a hypertension treatment initially, and then it was found to help as an antipsychotic agent. Similarly, if anyone has ever heard of the common hair growth substance minoxidil, that was originally a heart medicine that was found to cause hair growth as a side effect, undesired side effect, but then clearly it was recognized that hair growth might be desired for people who have trouble growing hair where they want it, and that's how that particular group of hair growth drugs became discovered. Another accident, sort of like the reserpine accident. Okay, phenothiazines. These in 1952, as you can see, chlorpromazine, Thorazine as it's commonly known, was introduced in the U.S. as an effective tranquilizer for psychotic patients, and it's a member of one of several of these phenothiazines, and they act as dopamine antagonists by blocking the postsynaptic receptors for dopamine, and as a result, they're effective in treating the symptoms of schizophrenia. So the 1950s gave rise to a lot of these antipsychotic agents, and gave another set of drugs in the arsenal of treating disorders like schizophrenia that had formerly been treated, unfortunately, by just locking patients away in a mental institution. Okay, now on to some antidepressant drugs, starting with the selective serotonin reuptake inhibitors, or SSRIs as they're commonly known. These are used to treat depression, and they enhance the effect of serotonin, which we said is commonly associated with good feelings, by blocking its reabsorption by nerve cells. So they allow that serotonin to persist, and therefore the serotonin can have longer lasting effects rather than being pretty immediately reabsorbed by the nerve cells. Looking at our group of stimulant drugs, we have the amphetamines, which have been used in treating depression and narcolepsy. These drugs increase the pulse rate and blood pressure, and induce excitability and restlessness. At one time, they were used as diet drugs because they do increase that pulse rate and therefore metabolism. But since they seem to reduce excitability and restlessness, they are now used in children to treat attention deficit disorder. However, we of course can't talk about the amphetamines without talking about methamphetamine, a commonly abused drug, and I think a lot of the concerns about that have caused the amphetamine class itself to be questioned for therapeutic value because of that high potential for abuse. Speaking of drugs that have some therapeutic value but high potential for abuse, we have cocaine. Now another stimulant drug. It's a powerful stimulant drug, and it used to arrive in the U.S. as cocaine hydrochloride, a very pure form, a form that could be snorted, injected, taken in a number of ways, but typically associated with high-end users, wealthy individuals. Now more recently anyway, and now it's like 40 years almost that it's been available. It's the freebase crack cocaine, and that's associated with less financially well-off users, so to speak. But both forms act by preventing reabsorption of dopamine. That leaves these high levels of dopamine to continue to stimulate the pleasure centers of the brain. Unfortunately, it doesn't leave it very long. That short-lived effect means that cocaine use is quickly followed by depression and a craving for more. You've had that taste of the pleasure centers being active, so now to have those pleasure senses less active, the depression that follows causes that physical addiction, that need for more of the drug to get back to that heightened sense of euphoria. Looking at a very common drug, caffeine, which is present in coffee, tea, and cola, for instance. The caffeine is a mild stimulant. An effective dose is around 200 milligrams. And if we look at some other sources, these energy drinks, like if you look in table 18.5 there, 5-hour energy, just 2 ounces of it has 138 milligrams of caffeine, so that's quite a lot. If we're looking at an effective dose of about 200 milligrams, we're almost there in just 2 ounces, whereas everything else is for a 12-ounce serving. So be very careful, especially with these energy drinks, because a lot of them have much more caffeine than other long-standing coffee, tea, or cola sources. Speaking of common sources of stimulant drugs, nicotine is another common stimulant, and it's typically taken by smoking or chewing tobacco, or any other of the various forms of smokeless tobacco. Initial stimulant response followed by depression, sort of like we talked about with the other stimulant drugs. Smokers are able to maintain almost a constant level of nicotine in their blood by regular smoking, or those who do smokeless tobacco or chew or whatever. Again, the nicotine itself is addictive, and we know lots of carcinogens and other undesirable substances typically in those tobacco products. So it's unfortunate and it's difficult, but there are some chemical agents available nowadays to try to combat that addiction and get yourself off of tobacco if you are indeed addicted, largely due to that nicotine. Okay, lysergic acid diethylamide, LSD as it's known, is a semi-synthetic, powerful psychedelic drug and synthesized by converting lysergic acid, which is a natural product of ergot, to its diethylamide derivative. And this is excellent chemistry, and actually the first person to ever be dosed with LSD was the chemist Dr. Hoffman, who synthesized this substance, and he wrote in his memoirs about his various trips on LSD. Tends to give rise to enhanced creativity. It's commonly abused among the art and music community as a result, and obviously can lead to negative trips as well, and therefore is a substance that should not be abused by anyone for any reason. We see a couple natural sources of psychedelic drugs. Psilocybin is a psychedelic alkaloid found in several mushrooms, and psilocybin has effects similar to those of LSD, which is a semi-synthetic. These are natural. Mescaline is another natural psychedelic drug found in the peyote cactus, and its effects can last up to 12 hours. And we see its chemical structure there at the bottom of the slide. Another psychedelic drug, marijuana, is prepared from the leaves, flowers, seeds, and stems of the cannabis sativa plant. Of course, the resin actually is the highest component of this major active ingredient, tetrahydrocannabinol, THC as it's commonly known, and we see the chemical structure of THC there at the bottom of this slide. It's been legalized for medical use in roughly half the states, and for recreational use in a number of states, and right to our immediate neighbor to the east, Massachusetts is the most recent state and the only state east of the Mississippi to legalize recreational marijuana. Washington, D.C., not a state, has legalized it already as well. Okay, so legal or otherwise, the abuse of drugs can cause a number of problems, and the reason they tend to be abused in the first case is for their intoxicating effects, and therefore if the individual who's abusing the drug is not thinking clearly anymore because they've been intoxicated, that can cause major problems not only for the abuser but for those of us in society who have to deal with the effects of an intoxicated abuser. Drug misuse is the use of drugs for the wrong purpose. So an example here is the use of antibiotics for viral illness. Antibiotics have no effect on viruses, but as I've mentioned already, a number of us have probably gone to the walk-in or emergency room or just our regular physician with a cold-like symptoms, likely of viral origin, but we're given antibiotics just as sort of a here you've got a prescription out of me, go and feel better, and that misuse contributes to the antibiotic resistant bacteria problem that we talked about earlier. And now one of the reasons that drug misuse is so common, in particular for the example we just talked about with getting antibiotics for viral infections, is because of what's known as the placebo effect. A placebo is an inactive substance administered as a medication to a patient, and strikingly, many patients demonstrate positive results when given placebos. They just get better because they think they were given something to get better, and it demonstrates that idea of mind over matter. It's also why a lot of studies will show that whether they're given the active drug under study or given a placebo, both groups tend to improve, even though the active group would only be the group that would be expected to improve. Both the placebo and the active component group tend to improve. So really, to judge the merits of the drug, you have to have significant improvement in the active group compared with the placebo group for the study to be considered successful. Okay, and lastly, new uses for old drugs. The development of new drugs is very expensive. It takes a lot of money, it takes a lot of time, and it's one of the reasons that the jobs in the drug industry, if you're a pharmaceutical chemist, it's one of the few areas that goes independent of the economy. So in good times and bad times, it doesn't matter what the economy's doing. If you're investing 20, 30 years in drug discovery, you can't be hiring and firing people just on a whim based on what the economics of the time are. So they tend to be pretty protected jobs, those pharmaceutical chemist jobs, because of this very issue that development of new drugs is a long and expensive process. As a result, a lot of older drugs have been tested and approved for new uses, and this is actually our application of green chemistry here for the chapter, because we've gotten good at making these older drugs. We can make them in large quantities, generally with very few wasteful side products. We've gotten clean syntheses of these drugs, and now we're finding new ways to use them, effective ways to use them to treat disorders like those that we've talked about, heart disease, cancer, so on and so forth. Then that's actually a win-win situation, because we've avoided having the lengthy and expensive new drug development, and we found a new way to use these older drugs that we've been very good at synthesizing. So it's been a pleasure joining you for these voiceover lectures, and I hope you've gotten as much out of the course as I've gotten out of getting to know you and work with you through the lecturing lab components. And I hope that you've acquired the skills that you needed and the reason that you took the course, and maybe, just maybe, you've gotten so interested in chemistry that you'll take another chemistry course and learn a little more and go into more detail instead of this single semester overview of general organic and biochemistry. All right, thank you very much. Hope to have another successful semester with you in another course in the future if possible.